Well, thank you very much, everyone. We are excited to be here today to talk to you about the Child Welfare and Addiction Fellowship Program. Thank you for being here. I know it's the last session, and we really appreciate you hanging on for us to talk about things. There's actually quite a few folks who I know who are in the audience who are associated with the Child Welfare Addiction Fellowship Program. I wonder if you would just raise your hand so other folks know. Thank you. Thank you for joining us. And we appreciate you being here today. So really, you'll see I'm going to just mention our collaborators here. There's some folks on this list who actually aren't on this room. This is a group of people who are working together to put together this training program. And it is a workforce development training program. So we are receiving funds to provide training for social workers who work in child welfare, to provide them with information on evidence-based practices and knowledge in addictions. And so we're excited to kind of tell you about our program. All right, let me see if I can manage the clicker and the microphone at the same time. We did want to just take a minute to kind of acknowledge our funders. We received funding from the National Institute of Drug Abuse. And also, we just wanted to say a huge thank you. I know I already asked people to raise their hands, but this training program wouldn't be possible without the fellows who are participating, as well as their agencies, and folks in state agencies just kind of supporting us and working on this project. So thank you to all of those folks who are out there who, whether you're attending virtually or you're here, for that support. We have introduced our panel, so I'm excited for you to get to hear from all of us. What I really like is we have this great group where we have a couple of our fellows who are here today, and they can talk to you about being part of the program. I don't know if you want to say something or you feel. Okay, so I'll just say a few words about everyone. What we really like is we have we have two folks who are fellows here today, who one is kind of from a more rural area, as well as another from Matthews County, as well as from Henrico County. So I think they're going to bring just different perspectives of what it means to be part of this training program and some of the needs that they're experiencing. And I'm also really glad that Kristen's here today. She's part of our training program and can talk about that. And I love that you got some really big cheers, because we feel that she's an incredible gem. She has experience in child welfare as well as addictions, and she brings a lot of great knowledge to our team. So we're really glad that she's here. So this is what we're going to do today. We're going to kind of tell you about what kind of led to us kind of creating the Child Welfare and Addiction Fellowship Program. Then we're going to tell you about our 3 training components and what they include. And then we're going to, we have done an evaluation, as was mentioned. And so we're going to talk to you about what we've noticed in terms of some of the gains that folks have reported from participating. We're going to do a little bit from, actually just a tiny bit from the surveys that we've asked our fellows to complete, and we're actually going to rely more on our fellows really talking about what it's like to participate and what they've kind of gotten out of it, and we're going to kind of end with kind of some takeaways and what we hope the future looks like for us. And then we have ourselves paced in a way that we hope that will allow us to have some questions from you all at the end. Okay. So let me just kind of start, like, what are the challenges? And none of this is going to be surprising to any of you. But whenever there are increased overdoses, whenever there are big changes in trends in substance use that happens in the community, this trickles down to our child welfare system and to our program. So this is just some research that's been done that shows that overdose deaths are associated with increases in foster care entries. This is probably no surprise to anyone. And then also some research really that's showing that something like up to 79%, there was a range presented for this study, of caregivers in the child welfare system, right, have substance use disorder problems. So it's a large need, and again, this is like a problem, there's the context of the problem that trickles down to the child welfare system. But really this divide, or kind of the disconnect we're finding, is we have some great folks here who have gotten their social work degrees. They've gotten a lot of really good information about how to work in the child welfare system, and they have kind of come to their job with all of that information, but they haven't received a lot of good information on substance use disorders, having that knowledge, or kind of evidence-based treatment. So this is a big part of this program. One of the things that we've worked really hard to do is actually recruit social workers from all over Virginia to be part of this training. All the training components are done virtually, so it allows us to have folks to kind of participate from different areas. And I did my best to do a little mark in Henrico as well as Matthews County. And so this is kind of just shows you where our folks are from who are participating on the panel today. And really just wanted to ask actually the both of them to talk in a moment, which really is, yes, there's these national trends, there are these national problems, and they affect the child welfare program, but then there's also local challenges that people are going to be in different agencies, different regions, and so they're going to face different issues.
So initially, when I was asked to speak here today about my experience in the child welfare field, I spent a lot of time reflecting on what it looked like for me coming into the child welfare field as a graduate from VCU social work program, coming from the child welfare stipend program, and having some of that foundational knowledge that you need to enter the workforce, but not necessarily feeling very prepared. I think there's a lot of realities of the work that we do in child welfare that isn't widely known, and so that's really what I want to touch on first. The first thing that's already been mentioned is substance use is a factor in a lot of the cases that we have, if not all of them at times. And if it's not initially the factor or the reason that we're coming in contact with a family, it's still something that we are asked to and that we need to assess for. Another reality of the child welfare field is some of our policies are very vague. We heard a little bit about that earlier. Some of the policies regarding assessing for substance use, working with individuals impacted by alcohol and other substance use disorders, it doesn't give us a lot of guidance to know what we really need to be doing to help that population. The other reality of the work that we do is we have very limited training on how to work with this population. I think that there's maybe a couple required trainings, but it's really just foundational knowledge. It doesn't give you the tools you really need to adequately meet the needs of clients and families impacted by alcohol and other substance use disorders. The other thing that I think probably a lot of people in this room, whether you work in child welfare or not, that can relate to is we have really high caseloads. We have a lot of clients that we work with, and we have a high turnover rate, so we don't have a lot of workers to do that work. We have a lot of requirements that come along with the job that we're doing. We're asked to do a lot of different assessments, and we have very strict timelines, strict time frames to complete this work. And so we're really being asked to make change happen really quickly in situations where that's just not always possible. And for me, what that looked like was I was burning out really quick. I found myself really struggling to feel like I was doing an adequate job and that I was giving the families I was working with what they deserved from a worker like me. The other reality of the work in a rural area that I think a lot of people in here can probably relate to as well is there's not a lot of services, there's not a lot of providers, and when you do find those providers, sometimes it's hard to help our clients access that service. I would find myself sometimes sending people an hour away for a service, and sometimes those clients didn't have transportation. So it didn't always feel fair to ask them to do that. One of the unexpected realities that I found when I started working in child welfare was not necessarily the stigma associated with the field coming from the families that we work with. I think it was pretty understandable that when you first come in contact with a family, they're going to be hesitant or fearful to work with you. One of the unexpected things was the stigma that service providers sometimes brought to the work that we do. There was a lot of times where I would contact a service provider and they wouldn't want to talk to me. They wouldn't want to give me information, and it was really hard to figure out how I could get a seat at the table and communicate that I want to be a part of that helping relationship and that I want to support the clients in the same ways that they do. And so I was finding myself really struggling to figure out how to do this work in a way that felt meaningful and helpful. So that's really been my experience, and I want to let Kate share hers as well.
Hello, everyone. I have experienced almost the same as what Rachel has experienced, except that I do work in a very well-resourced area here, the local Richmond area. I will say that, in addition, an area that I felt that I was lacking in knowledge was my ability to more effectively advocate for my families who are struggling with substance use disorders. And I mean being able to explain to all of the other hands in the pot when you're working with a family who's involved in child welfare, attorneys, CASA volunteers, providers for the children, other providers for the parents. A lot of times, as Rachel mentioned, we're not just working with families struggling with substance use disorders, we're working with families where there's also maybe domestic violence. There's a lot of parent-child relational issues. There's co-occurring mental health disorders. There's a lot of other things that we're working with families, and I felt that I was not always able to, especially in court, advocate the way that I wanted to, so that a family's needs, what a family was doing to work towards reunification, which is what I do in foster care. I work to get children back home with their parents. I felt that I was not always able to advocate for why a judge should grant a family more time, why an attorney, why like a guardian ad litem should maybe lighten up on a parent who is in recovery, who is in treatment, who has completed IOP, who is working their recovery plan. And so I think that is kind of an area that I was lacking, and then when this opportunity presented itself, I was very eager to take it. I also felt that I was not always kind of competent in how I could communicate with families about their needs when it came to alcohol use disorders and other substance use disorders. Because again, as Rachel mentioned, when we come in, there is a stigma attached to the work that we do at times, in that we are, sometimes like causing separation in families, which is really hard and really challenging. And we try to be able to serve everyone within a family, so the children, caregivers, parents. We work with a lot of families who we actually license as foster parents, who are connected to a family where they're fictive kinship. But we know, and I think, and I speak for myself in my own personal family, substance use, it impacts like all corners of a family. And so how do we also support those kinship caregivers who are taking care of kids while we are working to get those kids safely home with their parents? So that was an area where I really felt like in all of my exceptional social work education and supervision that I was getting, I just felt like I needed a little bit more support in that area. So now I'll pass it on to Kristen.
So that's where this program starts. So what they shared, their experiences in terms of maybe why they were interested in joining the Child Welfare Addiction Fellowship, I think is very similar across all of the participants who chose to sign up. I think everybody that I've worked with in the last 3 years has wanted to be there, wanted to grow, wanted the information, desperate for the information in how they can better support families. This presentation today, I think, has a little different angle than some of the other presentations, which are a lot about the individuals that we serve. And this one is, but through the workforce. This fellowship program is about supporting the workforce. I think Karen and Rachel both talked about the high turnover rates and engagement rates and burnout rates. We wanted to figure out how can we help mitigate some of that by supporting workers, employees, and trickle that down to the individuals being served. So this program has 3 components. It's a 2-year fellowship program. We are in our cohort 3, so we are in our third full year of this program. The 3 components are listed above, so weekly clinical supervision, it's a group supervision, often probably feels a little bit more like peer supervision in a way, and we'll touch on that too. The focus of that supervision, it's weekly, it's virtual, and it goes weekly for the first year. That actually catches some fellows off guard, that part only goes through the first year of it. But that, we'll touch a little bit more on exactly what it is in just a second. But the quarterly trainings are where we provide some education, standardized kind of structured curriculum education, and they get those also virtually every quarter for the first 2 years that they're participating in the fellowship. And then on a monthly basis, they participate in echo-style-like sessions every month for the first 2 years, led by Dr. Francis. And those are more complex case discussions. So we'll kind of dive a little bit into each of these components. So not that this is the most important component, because it's not, but it's the first component because I wrote the slide and here we are. So weekly supervision is, again, every week for the first year. I wanted to create a space, a safe space for the group of fellows to come in. I am not their supervisor. I am not responsible for if they got to work that day, if they've done their case notes, I am not connected to their job in any way, shape, or form, and that is so nice for me because I get to just be a safe space. That's my ultimate goal in the weekly supervisions, create the safe space, because there's not really anything magical that I do. I can share some knowledge, I can share some experience, I can ask questions, but it's them. It's them bringing cases to the table that they want to talk about. It's them posing questions. It's each other sharing resources back and forth. And I learned pretty early on in this process that they can do this themselves. This is them doing it themselves. I'm a conduit for that, maybe a moderator at times. And to watch the relationships develop and the resource sharing going back and forth has just been such a magical part for me, and why I love showing up every Thursday at 4 p.m. So compared to the echo-like sessions, which are more formal case presentations, I wanted to have a space where people could, if they had a difficult week, could come in and staff that difficult case that they just got out of court for. I didn't want them to have to be putting in a ton of time and thought into preparing case presentations because they're already doing that for the monthly echoes. I wanted them to just have that space to vent if that's what needed to happen. Because we know in our workforce, you might have a colleague that you can do that to, but in this space, you're gonna be met completely non-judgmental, and then you're gonna get that feedback too. It's not just about coming in and dumping it. It's gonna be ideas. Someone's gonna speak up and say, hey, I had a similar situation happen, and this is what we did, or have you tried this? But it's not your colleague that you have to go and you're passing a case off to. And so we've talked about a lot of different things in the weekly supervision. So it does end up being a blend of some training. For me, it's most important that the fellows walk away with a basic understanding of what a substance use disorder is and what it isn't. So we do that kind of foundational education. We talk a lot about how simply using substances does not equal a diagnosis, right? And parents can use substances, and it doesn't mean that it's, problematic. So we do some basic education about that. I also want to make sure that everybody walks out of there truly understanding the treatment side. So I myself manage the substance use services for Chesterfield County's outpatient program, but I started in child welfare. And so I get to blend both of those two worlds for me, and that's just kind of a magical space for me to be able to kind of relive through them kind of what my life was like almost 20 years ago. And so I want them to understand the treatment provider side. I want them to understand what happens when someone comes through same-day access, when they send their client through same-day access. If you're familiar with the Community Services Board language, that's that first assessment. I want them to understand the screenings that we use to make some of these determinations. I want them to understand the ASAM criteria and level of care placements and what happens when we might recommend residential, but that person has all of these barriers and can't go to residential, how we might work with them at a less intensive place to try and build motivation if that's what needs to happen. So they get all of that in between those informal case staffings. We talk a ton about systems. That has been a really common theme for what we've talked about over the last few years, is working within systems. A lot of discussion around the judicial system. We are thankful that we've got representation from across the whole state of Virginia. But with that also comes understanding that every locality handles things differently. Not just DSS agencies, but every judicial system handles things differently. So you may have a judge in rural Southwest Virginia who still supports removing children for parental marijuana use. That's a thing. It's happened. It still happens. And then you may swing the other end of the spectrum where you have cases where the worker and the agency have gone over and beyond, extended timelines, really tried to work with families and feel like they're at a junction for safety and still don't necessarily get that removal. So it really spans the gamut, but we get to talk about that. They get to learn from each other. They get to hear what other localities are doing. I learned about sweat patches from this group. I didn't know that that was a way of drug testing people. I had no idea. Been in the field since 2012 and didn't know that. So learning about how they're handling cases related to substance use, information sharing, resource sharing. We also talk a lot about mental health, and every cohort has had their own focus in clinical supervision. Cohort 2, I will say, had a lot of mental health cases that were impacted by mental health, a lot of it adolescent level cases too that they wanted to staff and support. So we do a whole kind of overview of all of those diagnoses as well and the co-occurring nature and their intersection. So that's pretty much the weekly supervision. Those are the things that we've talked about as far as trends over this period of time. And the quarterly trainings, we use a curriculum that's modified from the National Center on Substance Abuse and Child Welfare. There's a toolkit that's free online. They took that material, modified it a little bit, but these are the topics that we go over the course of 2 years. Because of the way that we staggered the cohorts, they overlap for one of their years. And like the first cohort had a whole year by themselves. But then the second year of training, they were with cohort 2. Same thing for the echoes. And then cohort 2 was with both of those, and now cohort 3 is with cohort 2 in the trainings and the echoes, but they'll be alone going into their second year by the way that the grant is. All of this training topic, we can work in the supervisions to dive deeper. And so that's another kind of beauty of having the clinical supervisions pair with that is it's a 2-hour training. And I tell them, I feel like I'm talking the entire time, rushing through this material. But the great thing is we have this year to kind of go a little bit deeper into some of those. So we're talking about the systems. We're talking about understanding the intersection between domestic violence and mental health, and how do you support parents while also developing comprehensive case plans and all of that. And then the third component are the monthly echo style sessions. And so this is 1 hour once a month, more formal case presentations where fellows have kind of signed up to present a case for feedback. They've put more kind of thought and preparation, thinking through all the case demographics and the history of the case, and thinking about what's the question that they're asking the team to help support them help support them on. These are de-identified cases, so we're not revealing any sort of confidentiality. We're maintaining confidentiality. But then also the neat part is they bring in guest speakers. So again, enhancing this learning and training about the field. And so 2 examples that we have up here that we've had in the last years. One, I think recently they had Chesterfield Recovery Academy, local recovery high school here in our area, come to one of the echoes to be able to share about that program, as well as Health Brigade, so talking a lot about harm reduction services in our area. Harm reduction has been a huge education component as well that's been involved in this fellowship, really trying to help child welfare workers understand what harm reduction is, how it can work within this spectrum of care, how it can work alongside child welfare too. We are all different systems with different perspectives, but working towards a similar goal. We just might have different timelines for how we get there, and we might have different ways that we approach it. But we all care and value the same things, which are healthy families.
Well, thank you so much. And we want to kind of tell you some of the outcomes, the things that we've learned about things that people who have been participating and how they've improved over time. All right, so we're going to just kind of show some findings from cohort 1. We've actually collected more data, but it takes a while to kind of dig in and kind of analyze that. And just as a reminder to folks who is actually participating in this program, these are graduates of Virginia social work schools who have child welfare stipend programs. So again, there are folks that are getting a lot of good information on how to work in the child welfare system, and we're kind of bringing them in for this workforce development training program related to addictions. And everyone who's kind of in this program is currently employed at a local DSS agency. And we really have focused on looking at communities that are in designated mental health professional shortage areas in rural regions. We're trying to make sure we're really doing a good job of covering those locations and places where people really need this training the most. And we have some data, just a little bit of data I'm going to present with you. For cohort 1, we've collected some baseline data and looked at how things are going about a year later. But then you notice, actually, I forgot to mention this, as Rachel and Kate were talking, there was kind of quotes that were up behind them on the screen. And these were quotes that came from some of our qualitative interviews about things that they have got out of the program and they've been experiencing. One thing I did want to mention is one of the earlier slides I did, it said up to 79% of cases when it looked at this national study had involved a caregiver who had a substance use disorder. And this is just actually some information about our cohort. And so fellows in our program reported an average of 56% of caregivers have had a substance use disorder, but that did range from 20 to 100%. So this is really the one kind of big take-home I want to present that's related to our survey data. And again, we collected this at baseline. That's kind of the lighter blue bar, and then the darker blue bar is at 1 year later. And there's 2 measures here. One is really related to alcohol, and the other is related to drugs. And we basically asked people kind of how adequate they felt. So is role adequacy, how much knowledge or skills do they have to effectively work with people who have substance use, who use substances. And what you could kind of see is just in 1 year, right, that people's kind of feelings about how adequate they felt in these 2 areas just increase substantially. And so we're really seeing that there's evidence that people are feeling better, kind of learning and feeling better about applying this information in their caseloads. Now, again, I think I want to just highlight that there's also kind of the qualitative findings that we found and we've taken a look at and we've kind of analyzed, but I also want to give back to Rachel and Kate and ask them to kind of talk about what they've learned and they've kind of gotten out of participating in the program. So I'm going to hand it to Rachel.
Thank you. So I shared earlier a lot about my initial journey in child welfare, the first few years that I was working in the field, and how I was on a really quick path towards burnout. which I think is where a lot of workers tend to head, and that's why we have such a high turnover rate in the field. And so really this fellowship program showed up at the perfect time for me, because I had a lot of expectations going in. I wanted to gain a lot of knowledge. I wanted to feel more prepared, and I wanted to feel more confident. I wanted to feel like I was capable of making meaningful change in the clients that I was working with and supporting them in a way that was more impactful than what I had been doing. And so I think that it's important to note that not only did the fellowship program meet all of those expectations, it went above and beyond and surprised me in a lot of ways with the outcomes that I was noticing in myself and in the work that I was doing. One of the things that I had mentioned earlier as well is that we have very vague policies in the state. Sometimes we're told we should assess for substance use. Sometimes we're told when we maybe could assess for substance use, but we're not always told what that could look like. And so for that reason, you see really big differences across the state depending on the locality that you're in for what that does look like. And having some of these times to interact with peers across the state, different colleagues who were doing things in a different way, was so meaningful. It gave the opportunity for me to take away ideas, kind of like the sweat patches, which I hadn't heard of either, to take away some of those ideas and try them where I was working too. Another really important impact that the fellowship program had for me was in my confidence. I felt like I could actually help the clients that I was working with. I've had some instances where I've been able to recognize when some of my clients have been prescribed medications that should not be taken together. A medication for an alcohol use disorder, for example, and another medical condition. And I know my role and I know my place, but I'm able to advocate for them in the sense that I can recommend that they talk to their doctor about that. And I've seen positive outcomes with that, both with people's health condition improving, but also the relationship that I'm building with my clients improving, because they feel like they can trust me and they feel like I can help them in some way. I think the other really important impact of this fellowship program for me, like I mentioned earlier, is reducing that level of burnout and giving me a space to talk to my colleagues and giving me the opportunity to give myself grace sometimes. The work that we do is really hard. Sometimes we don't always have the resources. We don't always know the best thing to do, and we're still doing the best that we can. And hearing that from people who know the work, know how difficult it is such a meaningful thing. I think the last way that the fellowship program was impactful for me that I really wanted to highlight is with being able to better speak with service providers. I mentioned earlier how there's a stigma associated with the child welfare field, and I was finding a lot of service providers didn't necessarily want to talk to me, but when I had this language and I had this knowledge and I knew how to advocate better for my clients and I knew how to better communicate what my goals were with what I was asking, people were more willing to listen. And that made such a huge difference, being able to collaborate with providers in my area and being able to confidently ask for the services that I felt my clients needed.
I think for me, one of the things that in my role working reunification with families, I work equally with children in the same way that I do with adults. And I think something that I do a lot is I also engage a lot with children's providers. And so kind of in conjunction with what Rachel was saying about communication with service providers, just growing in confidence when kind of transitioning more so to like collaboration on goals for caregivers who are in recovery, I can more easily translate that language when I'm discussing reunification to like a children's provider or like a kinship foster parent or anyone else who's involved with the family in that way. The other stigma that we encounter a lot in foster care is when we are ready to return children home. We oftentimes get pushback from people who only work with the children but don't necessarily see the progress that the parents have made. And I love being able to advocate for that and be able to share with people in an appropriate and confidential, respecting confidentiality way of like, these parents have made remarkable progress and they are in recovery, and their communication with their children about what being in recovery means is remarkable, and it's really strengthened, and that will continue to strengthen over time. I think that has been something that I felt a lot more confident in. I also feel a lot more confident in talking about the caregivers and the parents that I work with just directly in the home, in a casual conversation in the car about what they're going through on a day-to-day. What are the barriers that they are facing to get to the appointments they have, barriers to inpatient, and why that is so almost impossible for a lot of the families that we serve, to be very honest with you. And I feel a lot more, it feels like, for me, and I think as I build rapport with my families, a lot more like a collaboration. And I've had a few instances where I think people are a little taken by surprise that when I come in after a child has been placed in foster care, and when I come in with an openness and asking questions and a knowledge and a language that is about where are you in this journey and how can we help you get there, is maybe not taking clients by surprise, but I think is welcome in what is like the worst time of their life, the separation from their child. I also think that my ability to kind of connect a little bit more with those who are actually currently caring for our children in care, and to provide a lot of context and reframing and more person-centered language surrounding how are we talking about the challenges that these kids' parents are navigating right now. How do we talk about that in a way that is not shameful, that is not derogatory, and how can we collaborate with other people working with the family to ensure that that language is being reflected? I feel a lot more self-assured in that, and I find that I'm more quick to correct that language in a way and continue to do so over time with people that we're working with. I will also just echo that I think the opportunity to collaborate with people across the state is one of the best parts of what this program has offered. It's just incredibly validating. I think in all helping professional roles, any roles, it's just really helpful to be able to have a space where everybody has similar goals, a similar approach, a similar reason as to their why are we here, and to be able to say, like, this is hard, how are you doing this, how can I do this differently? That was incredibly validating, and very nice to have another space outside of the very supportive team that I already have. So it's been a wonderful experience, and I'm really pleased that there's been more cohorts since cohort 1. So.
I do promise we are nearing the end, as it's almost the end of the day. So what are our hopes? Where are we going with this? So our hope with this whole project is that we are building that knowledge and skills. We are giving the fellows the foundation that they're asking for, that we are developing folks to have a sense of expertise in this area that they can then take and share with their colleagues, so that trickle-down effect. We hope that can lead to even reflection and change in practice. These things that everyone has shared today, I don't necessarily know that I thought that this was what was going to come from it, but that peer-to-peer connection in the supervision, in the echoes over the course of the 2 years has been really, really magnificent to watch, and is something for us as we look for planning ahead. Where are we taking this? What do we want to do with this? Well, we want to figure out how do we make it more sustainable. We have had fellows have to drop out of the program because it is a lot of requirements to manage with an already existing heavy caseload. So how do we make this more sustainable, and how do we scale it? right? We've got 3 cohorts, and so that's a small N, right? And so those are some of the things that the team's going to be looking at and planning for. These are the things that we hope are impacting the field, that we are increasing knowledge, increasing confidence, but that's directly impacting the individuals that we're serving. That relationship between a child welfare worker and a parent is so crucial. When I got into this field, I talked about really wanting to change the stigma in child welfare, but to improve that relationship. Every single interaction is an opportunity to show that you care. And every person in this fellowship, I know they care deeply about the people that they work with. And so improving those outcomes for the families is ultimately what we hope is going to happen. And developing that sense of mutual support can reduce burnout in this field so that we might be able to sustain it.
We actually now kind of wanted to turn to your thoughts. We'd be open to your questions. And we also, again, we have some folks who are also participating in the program here, and we wanted to open it up to see if anyone else might want to say something or speak about what they've learned or about their experience. So, oh yes, I'd be happy to run around. I could be the run around person with the microphone. Any questions for us? Yeah. All right. Oh, you had to make it hard for me and be like that far away.
Thank you so much.
You're welcome.
I just have a question about what are you guys' thoughts on different judicial areas across Virginia having different forms and different ways of doing things? I know you're saying that it was kind of hard, but I understand that in certain, like if you're in the rural area versus like the city, they can have different needs. So what is your guys' thoughts on like different judicial areas having different requirements and like laws or ways they do things?
I'll pass it over to you as well. I think it's frustrating. I think it's really frustrating that someone could come and be served by my agency, be involved in the court system in Henrico County for whatever reason, they're coming to our attention. You could have someone have almost the exact same circumstances because there's no case in child welfare that is exactly the same, but you could have a family that has almost the exact same circumstances, be court involved in a different locality and have a completely different outcome. I find that to be very frustrating. One of the things that was surprising to me when I started child welfare was that judges at the end of the day are just people, and they have good days and they have bad days, and you often know when they are having a good day and when they are having a bad day. And I know that the assistant director of my agency is here. I know we try to do a lot of advocacy at the higher level to just communicate what we're seeing as the needs in our community so that at least we can say in our courthouse there's some consistency to the decision making. But I find it to be frustrating because yes, needs differ across localities, but if someone is coming to you with the same need, the consequences of that should not be different, if that makes any sense.
Yeah, I would just echo what Kate said in the fact that it is very frustrating as a child welfare worker to know that someone can have a different outcome in a different locality. I think another one of the realities that we talked about a little bit earlier about the child welfare field is I think there's a lot of expectation that we as child welfare workers make a lot, if not all of these decisions, and that's just not the case. There's a lot of times where we walk out of the courthouse and a child's just been removed and we don't necessarily always agree with that decision, but we still have to go with it. I think there's a lot of change that needs to happen in the child welfare system, but I think that there also is a lot of change that needs to happen in the legal system as well.
All right, thank you. Here we go.
All right, I just wanted to add as another child welfare worker, sometimes you'll get that within the same locality just amongst different judges. So you're not always going through different jurisdictions or localities and having differences of opinions, because like the panel said, they're individual people. So I would say, what I recommend to people is try to have some trust and faith in your attorneys, because ultimately they're there to protect your rights, and have some trust and faith in the guardian ad litems that are also there to look out for the best interests of your children. And the social workers, we're there to help be engaging and try to help and support you. But if we're not there yet, we're working hard to get that trust and build that relationship with you.
The other thing I'd add is figuring out in your locality, in your systems, what's your way to educate your judges, and figuring out how to do that. So in Chesterfield, I don't ring up judges. I mean, maybe in our recovery court, but our community corrections department has a great relationship with figuring out how to talk with the judges, providing education, bench cards, that kind of sort. So within every locality, it's trying to figure out what the advocacy points are to provide education. So in Chesterfield, we had a long way to go with acceptance around medication-assisted treatment. And it just was year after year of educating and educating and educating and advocating for that. And so, we've seen the progress. We still have ways to go, but it's just staying diligent.
Thank you all. I was wondering if there were a counterpart of this, like training substance abuse providers about child protective services. What would some of the topics that you all would want us to know about?
That sounds like a lovely new idea. So if you were training treatment providers in child welfare, what would you want the treatment providers to know? Is that what you're asking, or vice versa? Just like that, okay. So if you're training treatment providers on child welfare, what do you want them to know?
I feel like I would have to think about that a little bit more, but one of the biggest things is that we write court reports that get submitted to judges. Sometimes judges read them, sometimes they don't. But we do have an obligation to be really thorough sometimes in what we're sharing. And so I think, to Rachel's point earlier about providers being hesitant to share information with us sometimes about their clients in recovery, I understand that and I respect that. And I think it's really so just passing of knowledge about why it's important for us to be able to report progress to judges, to attorneys, to all of the other hands in the pot. And again, nothing not nitty gritty, not what is shared in session, but just us to be able to share progress is really important, yeah.
I think that's a really great point, and I try to tell the service providers that I work with that quite often, that I want the clients that I'm working with and the parents to get credit for all of the hard work that they're doing. And sometimes that means me getting that information and being able to share it in court. I think the other thing that I'd really want service providers to know is more about the policies that we have to go by. Sometimes we have policies that, I don't want to speak for everyone, but that I don't always agree with, that I think could probably be written better, that I think could be updated, that could be based more in research, but I'm still obligated to follow those policies. And so I think if providers understood the constraints that we were working under, they would be able to understand a little bit better the decisions that we're making when we're working with families.
So on the treatment provider's side, I was wondering if there was education about some of the, how do I say this, limitations of what's recommended by some of the parents or caregivers with a substance use disorder. Go get mental health treatment, go get substance use treatment, but then finding out at the CSB that we only can provide 12 sessions. And kind of that, is there training on that as well? or understanding.
And I think that's fair. I think that sometimes that is the case, and I think sometimes it's vague on purpose, at least for me, because I don't want to box anyone in. A lot of times I'm going to ask them to go get an assessment and follow recommendations because I don't want to dictate what someone is doing with their provider. That's between them and their provider. I want to know that they're getting taken care of. I want to know that their needs are getting addressed, but I don't necessarily want to confine what that looks like, if that makes sense.
And I'll just add an example. When I started in this role, one of the first families I was working with, it was primarily mental health concerns for the caregiver. And she actually got her children back, which was wonderful. But one of the, when I inherited the case very early, the initial service plan had already been written, and there was a recommendation that the parent get anger management. Well, the parent completed a psychological evaluation, and anger management was not one of the recommendations. And it came up at one point in court, well, why didn't this parent do anger management? Well, the parent didn't need anger management. And so I think there are some things that us in our role, we feel comfortable recommending, but I don't want to box parents in, and I certainly don't want to be put in a situation where I recommended something and it ended up not being what the need was. And sometimes it's tough because we are required to submit service plans within 60 days of children entering foster care. It's not a ton of time to get to know. I mean, it's a decent amount of time to get to know a family, but you learn so much more, as you all know, like as you build rapport and everything about what a family's needs are. So I think that's kind of, I understand why sometimes it's difficult to get that vague request, and a lot of our judges love to court order that our clients go to Henrico Mental Health and get a substance eval, complete treatment, but then sometimes, the judge would then question what the recommendations are. So I completely hear you, and that's just a little bit of our rationale, if that makes any sense. So, yeah.
So circling back to a training, so I think a good cross-reference training for service providers and child welfare professionals, I think would be something related to harm reduction and like safety and risk factors for children, just so that both professionals can kind of understand the factors involved for both and how it looks at abuse and neglect, because two can be present and not be a factor impacting an individual. So I think that would be great for a treating provider to know that, hey, we're reducing harm, but it may not be abuse and neglect, because sometimes from child welfare, we're saying this person is in this treatment, but they're still having positive tests for X, Y, and Z, and we can't return a child specifically because of this test result. But for a treatment provider, they're saying, hey, this is successful. We're meeting all the goals. And on our end, it's like, no, they're not. And we can't return the child in that setting. So I think some type of cross-reference training would be a great for both parties.
Yeah, and I think this kind of goes to the question asked to my left in regards to service providers and us asking for requests at child welfare agencies of service providers, and then the parents not being able to meet our requirements. It's so important to me to collaborate with our community organizations and our service providers in the locality that I work for, so that I'm aware of what's going on and what's offered within those programs and the expectations of the clients that I'm going to be referring to you. With that collaboration, I think it'll bring more understanding among all providers.
Thank you.
So I think a great way to wrap that up is connection, collaboration, communication, right? It's just all of us being on the same page, sharing each other's perspectives so we can understand and grow and figure out how to work together. Thank you all so much for your time today.